Good morning. I'd like to call the meeting of the Senate Health and Human Services Finance and Policy Committee to order. It is Tuesday, March 18th, 2025, and we do have a quorum present. Today we have several bills on the agenda, and our first bill on the agenda is Senate File 1494. Senator Miller. Welcome to the committee, Senator Miller.
Thank you, Madam Chair. Good morning, members. Senate File 1494 is a very important bill to me. Clearly, I'm in front of this committee first on the agenda. This is a very prestigious committee, so we thank you very much for your time this morning. Senate File 1494 is a bipartisan effort to add metachromatic leukodystrophy, often referred to as MLD, to the newborn screening panel here in Minnesota. Before we hear from our testifiers this morning, I'm going to share a few facts about MLD. According to the Mayo Clinic, MLD is a rare genetic disorder with symptoms that include loss of motor skills like walking, speaking, and swallowing, loss of intellectual thinking and memory skills, loss of the ability to detect sensations like touch, pain, heat, and sound, and even loss of vision. According to the Cleveland Clinic, researchers estimate that MLD affects about 1 in 40,000 people in the United States. There are 3 types of metachromatic leukodystrophy, which are infantile, juvenile, and adult form. And according to brainfacts.org, most children within the infantile form die by the age of 5. While there's currently no cure for MLD, there are treatments available to slow the progression of the disease, as well as treatments to manage the symptoms and enhance quality of life, which is why newborn screening is critically important. The benefits of newborn screening is early detection and diagnosis, so treatments can begin before it's too late. It also provides families with information, guidance, networks of people, and medical professionals to help them navigate through an unimaginable situation that has become their new reality. Madam Chair and members, I believe we have a couple testifiers who are remote. We'd like to go to them first, and then I'll turn it over to the Quimby family who are with us today from Winona.
Great. Okay, thank you. We have Dr. Julie Isengard. And if you can please state your name for the record and begin your testimony.
Good morning. Thank you so much. My name is Dr. Julie Isengard, Madam Chair and Committee. It's a privilege to be here. I'm an associate professor and pediatric neuropsychologist at the University of Minnesota, where I serve as director of the university's neurodevelopmental program in rare disease. The program includes more than a 30-year history of measuring the impact of rare diseases on the child's abilities, independence, and quality of life. And metachromatic leukodystrophy, also known as MLD, is one of the rare diseases we specialize in. MLD is devastating. Beautiful children begin life just like all children should, gaining skills and new abilities, but then they tragically lose them. Through our work, we have quantitated this devastating course. Children with MLD continually score lower and lower on repeated assessments, including scores for IQ or intellect, communication, processing, physical coordination and play, and quality of life. Because we know untreated children with MLD will show dropping numbers, we can tell whether treatments work or not. If a treated child shows better scores than we see for untreated children, we know the treatment is working. For MLD, gene therapy allows for very different and much better scores. They show the gift of development forward rather than regression backward. We and our colleagues have found a caveat to this, and it's the timing of treatment. So when MLD begins to rob a child of the skills that they rightfully developed, there's no catching back up and there's no going back to normal. And so there is no time. There's no time to wait for an MLD diagnosis that comes only because a child has lost skills. In contrast, children who are treated before MLD begins eroding their skills, they do not lose abilities. Repeated assessments of these treated children have shown, without exception, higher and higher scores of clear developmental progress. Not only do their abilities increase, but they have a quality of life that children deserve. Playing, running, jumping, talking, joking, laughing, and they do not lose these skills. How do we know this? Most of these examples are children who were diagnosed by the traumatic sacrifice of an older sibling with MLD. When that sibling lost their skills to MLD, doctors knew to test for it in the younger child because MLD is a genetic disease. So that younger child was treated while MLD was invisible, and it stayed invisible. Right now, these success stories mean that families need to lose a child to save a child. And this story of tragedy and success does not need to be mixed. With newborn screening, all of the affected children have a chance at treatment while MLD is still invisible to keep it invisible. We know newborn screening works, and all children deserve a chance at a timely diagnosis. The state of Minnesota has been a leader in newborn screening, and we can and should continue to save the lives of all of these children. Thank you.
Thank you very much. Next, we have Jennifer Braun. If you can please state your name for the record and begin your testimony.
Good morning. My name is Jennifer Braun. I'm a nurse practitioner and a clinical director within the Clinical Trials Office at the Masonic Cancer Center at the University of Minnesota, working with pediatric patients in the field of cell, gene, and immunotherapies. I've worked with patients with inherited metabolic disorders, including MLD, for almost 10 years, and greatly appreciate the opportunity to speak with you all today. As Julie mentioned, MLD is a rare recessively inherited genetic disorder, meaning that in order to have MLD, a child must inherit a disease-causing gene from each parent. The parents carrying these mutations have a protective, non-affected gene, making them asymptomatic. Quite literally, they have no idea that they are carrying a genetic mutation that can have devastating, lethal outcomes for their child. At time of birth, children with MLD are completely normal. They initially meet developmental milestones as expected until they don't. MLD is a rare disorder, and initial cognitive and/or neurological symptoms are often not overtly diagnostic. What this means is that most patients undergo a diagnostic odyssey that lasts several months before they reach a diagnosis. For most patients, those months trying to reach a diagnosis can cost them their lives. For the few patients who are symptomatic but diagnosed quickly enough to potentially benefit from therapy, any symptoms that they've already developed are irreversible, which typically has a permanent impact on their quality of life. The primary way we currently catch patients before they develop symptoms are in instances where an older sibling is symptomatic and diagnosed, prompting testing of younger siblings who may not yet be symptomatic. Close to a year ago, I helped administer a curative therapy to a healthy baby with infantile MLD. There was joy, but also sadness as we celebrated saving the life of the baby, whose diagnosis was only made possible by his 4-year-old brother, who sat propped up and comforted by a parent in the same room during the last months of his life. These don't have to be our only two options: a diagnostic odyssey that leads to a lifelong impact on quality of life or death due to disease progression, or diagnosis of a younger sibling at the cost of their older sibling. With newborn screening, we can identify all patients with MLD prior to them developing symptoms, allowing us to offer treatment that's now licensed in the U.S., and with it, a hopefully very long, quality-filled life. Although I wholeheartedly believe that MLD newborn screening should be implemented throughout the U.S., we have to start somewhere. A Minnesota physician, Dr. Paul Orchard, surely felt this and found a pathway for us in Minnesota to offer this therapy compassionately starting in 2021. There's a great Minnesota documentary out there if you're interested in watching called Sequencing Hope about this first patient treated. We're also the first state to treat 2 additional patients with licensed therapy. Making this therapy available here in Minnesota wasn't easy, but it was the catalyst for FDA approval of a curative therapy for MLD in the US. I know adding MLD as a newborn screening test isn't necessarily the easiest thing either, but this isn't the first time action taken in Minnesota has led to a nationwide impact. Thank you for making MLD newborn screening a priority in Minnesota.
Thank you very much. And now, would you like to proceed? Nick and Shanna Quimby are here, and whichever wants to go first, and just please state your name and proceed.
Hello, I'm Shanna Quimby. I'm a parent advocate for my son Gavin, who died of MLD, but I will be speaking written testimony from Professor Michael Gelb from the University of Washington Department of Chemistry. My lab at the University of Washington developed the method for newborn screening of MLD. We carried out the first pilot study by testing 30,000 newborn dried blood spots using the method of analyzing the sulfatide lipid and then the ARSA enzyme, both of which can diagnose MLD, with the machine, a mass spectrometry. This is the machine that will find the MLD in the child. We found 1 true case of MLD and 0 false positives, which is a very remarkable result. As far as false negatives, we expect none based on the fact that when we took 40 newborn dried blood spots from patients that went on to develop and be diagnosed with MLD, and all of them tested positive. The mass spectrometry newborn screening assay for MLD can be added to ongoing panels of diseases now being screened across the USA, including the Minnesota Newborn Screening Lab. Laboratories will just need to add a liquid chromatography module to their existing mass spectrometry equipment, which increases the equipment cost by about 20%, and some of the labs have these already. Once the module is added, the following diseases can be done by a single analysis. Number 1, MPS 1 and Pompe disease. This is already being carried out by the newborn screening program. Number 2, MPS 2 and Krabbe disease. These will soon be added to the newborn screening program, and they are also recommended on the screening panel federally. Number 3, X-linked adrenoleukodystrophy, and this has been on the panel now for about 8 years. And 4th, MLD. This analysis is easily expandable to include other diseases that are likely to be added to the state newborn screening panels in the upcoming years. All regions to add MLD are commercially available, including assay regions and validation standards. Initially, labs can add MLD as a laboratory-developed test, and an FDA-approved MLD newborn screening method is expected in 2006. I'm not a scientist, so I was really trying to get through that, just a parent advocate. And that was Dr. Michael Gelb. Thank you.
Thank you, Mr. Quimby.
Good morning, and thank you for having us here this morning. My name is Nick Quimby, his wife Shanna, and we are here testifying today in memory of our son Gavin. Gavin was diagnosed with MLD when he was only 3 years old, back in December of 2013. Gavin died from complications of MLD at the age of 5 in September of 2015. Gavin was a funny, sweet, empathetic kid. His personality and smile won everyone's hearts over. He was our beautiful boy who was taken too soon. MLD is a swift and devastating disease that is difficult to be successfully treated without early detection. Gavin's diagnosis came too late, and the journey there was long and painful. As the doctors noted, Gavin lost his abilities to walk, to play, to talk, to smile, to swallow, and breathe. They all withered away each day until he passed away. Every minute counts with this disease. The sooner the child is diagnosed with MLD, like at birth, the sooner treatment can begin. Gavin didn't have this option because the technology for MLD newborn screening wasn't available. It is now. Also, Gavin didn't have a good treatment option. Today, there are great treatment options, as explained by the nurse practitioner, which they're performed right here in the state of Minnesota, down the road at the University of Minnesota Masonic Children's Hospital. The U of M is a world-renowned leukodystrophy center. With newborn screening, these newborns testing positive for MLD would have the best chance in the world to be treated successfully and to live the life that Gavin couldn't. The science and technology are here today. The time is now to add MLD to Minnesota's newborn screening panel, so no child will have to suffer like Gavin and other MLD children have. Thank you for your time.
Thank you for sharing your testimony, and I'm very sorry for your loss, and thank you for being such advocates for other families to be able to avoid that. So that concludes the testimony. Members, do you have any questions or comments about the bill? Senator Ebler.
Well, thank you for coming. I don't know why. Jeez. I've sat on this committee for a long time, and periodically families come up with something I'd never heard of that they had a struggle with in their family, and now let's screen for it. And it seems like it usually works out that we can start that, and I'm just sorry we didn't know to add that before. So, I mean, it's really compelling that we should add this to the screen. So, Madam Chair, is there any reason this is not going to happen this year, do you think? Is there money challenges or opposition from the department, or any reason this can't just be done?
I think that, gathering the information, it sounds like there's definitely, the research and evidence. I think the Department of Health, what I understand is that the Department of Health has a process laid out for adding new items to the screening panel, and that this is something that is being considered. The timing of how their process works and our timing isn't maybe necessarily lining up exactly right, but I'm hoping that, by hearing the bill today and laying it over and, getting a fiscal note and then understanding from the Department of Health, because the bill, is implementing it rather than the current process of the analysis and decision-making, just want to understand how that would work and what the cost would be.
Well, thanks.
Senator Abler.
Thanks, Madam Chair. And Senator Miller, you've been active in this for a long time. And I don't know why I just get weepy about this, but it's, it just seems to me, Madam Chair, that our Department of Health, God bless them for what they do, they should be thinking of this. And with these parents, once you discover that there's some test for this, we should just do it. And so I'm happy you can try to do something, productive as you look back, but hopefully we can remind them to look forward so there's less parents sitting in that chair. Thank you, Madam Chair.
Thank you. Senator Bolden.
Thank you, Madam Chair. I will just echo more of the same, and thank you to the two of you for being here and telling us about Gavin, and I'm very sorry for your loss. Thank you, Senator Miller, for bringing this. I do hope we can move this forward as technology expands. I imagine there will be more bills like this as we have the ability to screen and test for more of these rare diseases. And so often we see that the timing is key, that treatment early, it makes a huge difference in these cases. And so I do anticipate we will continue to see more of these, and that's a good thing. We should be keeping up, our policies and our procedures should be keeping up with the technology and the ability to diagnose and treat these rare diseases sooner. So thank you for the work on this, and I do hope we can move this forward. Thank you.
Any other questions, comments? Senator Hoffman.
Thank you, Madam Chair. And it reminds me of not as long ago, it's 26 years since you've been on this committee, but 12 years ago, there was some more newborn screening stuff that needed to be added, that wanted to be added, and they found through a series of, fees that were added. I remember Sam Walseth might have been the one who had worked that out, but there's a way around this, to be able to do it, because it is a billable process, third-party billing plus the MA side of it. So I would just advocate that you seek those options out that are there. So I know it's going to be aligned, because this is absolutely, any of those newborn screening things, they're very essential to families. So thank you for bringing this. Thank you, Jeremy, for doing this.
Thank you. Senator Miller.
And Madam Chair, I do have some closing comments before I do that, just to answer Senator Abler's question. There is a newborn screening advisory committee in Minnesota that works closely with the Department of Health. They had a meeting in October, and this was on the agenda, adding MLD to the newborn screening panel in Minnesota. Unfortunately, that vote was unfavorable. My understanding is it was close. But unfavorable to adding MLD to the newborn screening list. With that said, I met with the Department of Health, representatives from the Department of Health yesterday, and the Newborn Screening Advisory Committee is meeting again on April 15th, and I'm told that they have some additional information available to the committee members that was not available during that October meeting. So we are hoping for a more favorable vote from the Newborn Screening Advisory Committee. That would be my preference, would be to go through the process that is currently laid out. However, since that committee, they met in October, now they meet in April, since they don't meet as often as we do, if we don't get a favorable outcome, my ask would be for this committee to include this in the omnibus bill at the end of session, because it is so critically important, especially the timing that we heard from the medical professionals and the families with the Quimbys. And I'll just end with this, Madam Chair. The Quimbys face the unimaginable loss of their son Gavin, and they're here today to share their story in an effort to raise awareness and highlight the importance of adding MLD to Minnesota's newborn screening panel. They are committed to helping make sure Minnesota families can get early detection and diagnosis so they have the best possible chance of a positive outcome. And I'll say that this is truly the definition of a grassroots effort, and I think it's pretty darn special for the Quimbys to be involved in this. You guys truly should be applauded for your efforts, along with the other families here in Minnesota who are advocating on behalf of adding MLD to the newborn screening list, because your efforts will literally help save lives here in the state of Minnesota. I could not be more proud to be on this journey with the two of you and all of the advocates, and I want to thank the co-authors on this bill, Senators Bolden, Coleman, Housley, and Hoffman. Thank you, Madam Chair and members.
Thank you, Senator Miller, and thank you for the additional information. I think that gives us, we have information that we are considering, and we'll lay the bill over and certainly give consideration to all of the factors that you've indicated. And again, thank you very much for being advocates. It's amazing what we learn every day through science and research, and being able to apply that to help children is certainly an amazing thing, and we want to take advantage of that. So thank you. And Senate File 1494 is laid over for possible inclusion.
Thank you, Madam Chair and members.
Thank you.
When you're ready, Madam Chair, to Senate File 2322.
Thank you, Madam Chair. I'm pleased to be able to present Senate File 2322 today, which would establish a healthcare workforce advisory council. This healthcare workforce advisory council would be one that would use data analysis and research. It would draw upon existing sources and entities and use this information to perform workforce planning in a collaborative and coordinated manner. Learning from other states that have already established councils went into the research that is contained in the report that you've received. That would be also a part of an ongoing effort to establish a council. The council would provide recommendations to the legislature and other stakeholders regarding healthcare workforce needs. It would help us to draw out what are our priority opportunities and priority needs in the state related to the healthcare workforce, and also help us to ensure that we have better, more efficient distribution of our investments. We have many investments in healthcare workforce programs, but there's no one to really coordinate or look across all of them to see if we're using our resources in the most effective manner. The bill origin is from one of the University of Minnesota Academic Healthcare Center task force recommendations in 2024, which I had council turn into bill form, which directed the Department of Health in consultation with the University of Minnesota and Minnesota State Health Force Center of Excellence. It instructed them to develop recommendations for council and to deliver a report, which you have in your packet today. 3 of the primary planners who worked on the report are with us to testify today, so I'd like to move to their testimony to describe their work. So, thank you.
Very good. First up, we have Dr. Prasad. Welcome to the committee. Introduce yourself and proceed with your testimony.
Madam Chair, council members, my name is Shali Prasad. I'm a professor of family medicine. I'm the Associate Vice President for Rural Health at the University of Minnesota. I've had the privilege of working with folks at the Minnesota Department of Health to come up with some of the recommendations for setting up such a council. My background is in primary care and public health, and I've worked in underserved areas, particularly rural areas. I was a rural doc for about 10 years. And one of the things we see, even in Minnesota, which boasts a world-class healthcare establishment, is that sometimes we are not ready in handling some of the challenges. And I do feel that this is going to be an ongoing issue with newer technologies, artificial intelligence, newer challenges to healthcare. And having a reactionary approach sometimes takes time. Development of healthcare workers takes time. So establishment of such a workforce would be a way to plan for the future in a way that is important to consider all parts of the University of Minnesota, all parts of the state of Minnesota, to make sure that the workforce in healthcare is there to serve communities, areas of the state, and fields that might be evolving. For example, if we look at the growth of telehealth, we feel that some of the tools needed for future work in the field of healthcare will be new sciences, new ways of understanding diseases, new ways of communicating with people. So the Healthcare Workforce Council will add to recommendations in setting up workforce training programs across the state, make sure, like Senator Wiklund indicated, that investments from the state are well used. Thank you.
Thank you. Next, we have Tricia Todd. Not sure if she's in person or on Zoom.
Good morning. My name is Tricia Todd, and I'm the director of the Pre-Health Student Resource Center at the University of Minnesota. As someone who has spent over 20 years in an office with the mission of supporting students in exploring, preparing, and applying to health profession programs, I support the development of this council for a variety of reasons. I think we need a more coordinated effort to really understand the workforce needs of Minnesota now and into the future, as Dr. Prasad mentioned, and to do this in a holistic way, not profession by profession or even school or program by program, all of whom have vested interests that can sometimes get in the way of serving the greater good of Minnesota. We also need a council that can really represent all of Minnesota and can help us develop big picture strategies while at the same time meeting the needs of specific communities and populations. The council would allow for and even invite differing perspectives in a space where quality discussion can help us construct health workforce solutions that serve the entire state. And the council will allow us to have a more coordinated data collection and analysis plan, which is essential if we want to make high-quality, data-driven decisions about what actually will address the health workforce needs in Minnesota. And finally, there are many things that affect the health of Minnesotans, but the health workforce is primary among them. And so I think we owe it to the people of Minnesota to create this council. Thank you for allowing me to share my perspectives.
Thank you. Up next, we have Valerie DeFore. Welcome to the committee. Please introduce yourself in person.
Good morning. Madam Chair, members of the committee, my name is Valerie DeFore. I'm the Executive Director of the Minnesota State Health Force Center of Excellence. Minnesota is fortunate to have many agencies, organizations, committees, and groups that are focused and deeply involved in and committed to Minnesota's healthcare workforce. Some are focused on a particular occupation, some on a particular delivery system, some maybe are focused on data. Even those that have a great breadth and depth, like the Healthcare Education Industry Partnership Council, which advises my organization, Health Force, and is made up of state agencies, associations, employers, and educators, have natural boundaries on the topics that we tackle. Having a statewide healthcare workforce advisory council, as envisioned by Senate File 2322, would not replace the great work already being done, but would elevate it. The advisory council would be positioned to bring together the expertise of many, to synthesize and analyze and sharpen it into legislative recommendations. No healthcare workforce shortage or need is as simple as it seems at first glance, or as it seems when looking at it from one point of view. And I am sure your committee can relate to that. Any occupation, whether it's physicians, nurses, or any allied health occupation, needs to be looked at from all sides. And as an example, I'll just choose medical laboratory scientists. If we start just on the supply side, so I'm already narrowing my scope, do we have enough programs? If we do, are they full? If they are, can they be expanded? If they can we find enough faculty? If we can, are there enough clinical sites? If the answers to any of those questions are no, we need to approach it differently. Maybe the shortage, looking at it from another lens, could actually be solved through increased retention, or a career awareness campaign, or building in pathways. So it's important to take a comprehensive approach, and the Workforce Advisory Council will help Minnesota do just that. Another example, and I'm going back in time here, is the 2015 Mental Health Workforce Development Plan that Minnesota State and Health Force completed as required by legislation. Taking a comprehensive approach to the mental health professional workforce with an advisory group, 17 of the plan's 24 recommendations were implemented in whole or in part by 2017. And I share that because there's a power in that approach, and that type of approach is what's envisioned in this legislation. As the healthcare workforce needs continue to grow, the need for data-driven strategic investment in workforce initiatives will be increasingly important. Minnesota has healthcare data in a wide variety of places. The Healthcare Workforce Advisory Council will be able to streamline data collection and analysis efforts and provide a trusted source for key data elements needed by everyone doing healthcare workforce work. In closing, I think Senate File 2322 leverages the strengths of Minnesota's Department of Health, our collaborative spirit, the existing healthcare workforce efforts, and will serve us well into the future. Thank you.
Thank you. Members' questions? Senator Rucky.
Thank you, Madam Chair. Looking at the makeup of this council, when I get to 10 members appointed by the governor, are we just picking people who are aligned with what the council's agenda is, or are we going out to get people that are really going to bring data to the table? That my concern is that this place, all it does is create councils and study groups, et cetera. And I don't know that we ever accomplish anything. So that's my concern with this.
Senator Wiklund.
Yeah.
Ms. DeVore would like to.
Yep, go ahead.
Sure. Yes, members of the committee, we, as part of our planning, looked at similar models in other states in coming up with what this committee or this council might look like, and talked a lot about what the committee structure and how that might be formed and the pros and cons of different models. And to your point, I think we envision the appointments being people who bring direct expertise in the healthcare workforce space to the council. And in fact, and there might be some language to this effect in the legislation, but the council might have priorities from year to year or from a 5-year work plan to 5-year work plan. And so those appointees could be selected based on actual priorities established based on the council's work and with legislative priorities being set. So my hope and the planner's hope is that the appointees would bring real strengths of expertise to the group and not be figureheads or placeholders.
Senator Rucky.
Thank you, Madam Chair. And I fully agree. I hope that that's the agenda. And actually starting with an agenda of some sort or some sort of a direction is a good deal, even if it goes totally different. But at least you've got something to start the conversation, and they've got a so-called goal in mind and something to move forward with. So thank you for what you answered with, and we shall see how this goes.
Senator Abler.
Well, thank you, Madam Chair. And, you know, it seems like a worthy goal, another group, another healthcare task force, but it's, I hope that if someone, with the priorities of our money, I don't know how much this is going to cost. And so it may just be an idea that you're bringing forward to, to analyze this with, we better plan for the future because we're short of everybody. That's my first finding out of the task force. We need more of everything. But if this doesn't go forward, Senator Wiklund and others, I think the U would be a good place to get this going. They already have the more we can have places like that with expertise, and we would maybe trust what they came out with, and their words might matter. Sometimes these advisory boards, they come out and like, oh, thank you for that, and then we do whatever we want anyway. But I think it's a real need. DEED is doing this some way, but I'm going to remind everybody, the U has more than 500,000 alumni, maybe much more than that now. Many of whom are retired doctors, really smart researchers, really smart nurses, smart business people, who really have time on their hands, and they would love to do this just for the price of a free lunch and free parking. And I've said that before, that's why it's not novel, but we do have a really big thing on our hands, and it's not going to solve itself. So thanks for taking a run at it.
Other questions, comments?
Comments?
Seeing
Madam Chair.
Senator Wiklund.
Dr. Prasad, would you like to comment?
Thank you, Senator, Madam Chair, and members. That is a very good point. The question when we were putting together the language behind this council recommendations was trying to figure out if I can use the word agnostic center. And part of it is, and I'm just as guilty as everybody else because we tend to look at our own professions first. So I am looking at, as a family doc, as a physician, what does the workforce need? Obviously, it's very important. I'm not saying it's not important. But I feel sometimes we have to elevate the discussion to a different level where it's the state's need. And so is there a way for us to do it beyond our individual disciplines or beyond our individual institutions? So that was the impetus behind some of these recommendations. But you make a very good point about coordinating with others in making the work of this council better. Thank you.
Senator Wiklund, any closing comments?
Did you want to make Ms. DeFore as a comment?
Yes, Ms. Ford.
Thank you, Madam Chair and committee. I just wanted to follow up and thank my colleague for those comments. To Senator Abler's comments, I think it is important to acknowledge, and something that we try really hard to do at the Minnesota State Health Force Center of Excellence is to understand that Minnesota's healthcare workforce comes from all healthcare educators and institutions in our state. So Minnesota State plays just a key role in educating healthcare workers, as do our private colleges and as does the University of Minnesota. And so I think agnostic was a great word to use. And I think what the advisory council would do is envision something that does bring all of the educators and all of the institutions of higher education together in such a way that is neutral and acknowledges the strengths and roles that we all play in ensuring that Minnesota has a strong healthcare workforce going forward.
Senator Wiklund.
Madam Chair, and just, in closing, I think that my testifiers have explained well, what would be the advantage of having this at the state level. I think for me, a couple things that are missing are the way to connect our knowledge of professions and what are the needs to what would be legislative recommendations. I was looking back on what we approved in 2023, just some of the investments we made in workforce, healthcare workforce. We had mental health training grants. We had additional practitioners in different fields. We had clinical dental education grants, rural training tracks and rural clinician grants, international medical graduate training grants. I guess, my point is that we have a lot of different items that we are funding, but I don't feel that we have a good sense of how well these are addressing the needs, and then how well are we coordinating? Are we missing areas that we should be investing in? And as Dr. Prasad mentioned, as time goes on, are we missing out on trying to get more people into areas that are going to be more important in the future? So that is, one of the reasons I feel that this bill is needed. And also, it would be a more longer-standing structure available for multi-years. It doesn't have it's not like a 2-year thing that's set up. It would be an ongoing entity that would be available to help us do this work. So I appreciate being able to present the bill today. Thanks.
Thank you. The motion is for Senate File 2322 be passed and be re-referred to the Committee on State and Local Government. All those in favor signify by saying aye.
Aye.
All those opposed? The motion prevails. Thank you, Senator.
Thank you. Okay. Senator Mann, Senate File 2152.
Thank you, Madam Chair. Members, 2152 is the Medical Assistance Directed Pharmacy Payment Program legislation. Pharmacies are closing across Minnesota at an alarming rate, and patient access to critical medication and pharmacy health services is at a tipping point for hundreds of communities across Minnesota. 40 community pharmacies have closed in Minnesota since 2023. The reason for this is varied, but one common denominator is a vast majority of prescription medication pharmacy claims by both commercial and public insurers and their PBMs is reimbursed at less than the cost to the pharmacy. The math obviously doesn't add up, and this is not sustainable. This means that Minnesota pharmacies are not being reimbursed for the cost of the medications they purchase and the cost of dispensing that medication to the patient. This is particularly problematic for patients on MA, which is about 23% of the patient population. Minnesota pharmacies are reimbursed by MA for dispensing medications to this population in two ways. About 15% are reimbursed through a fee-for-service program, which is a direct payment to the pharmacy from DHS, and the remaining 85% are through MCOs and their PBMs. So as we will discuss during the next bill, it is no wonder that pharmacies are not getting paid properly. So this bill would act as a bridge until we can get another better system in place, as we will discuss again in the next bill, the single PBM system, to keep our pharmacies from going under. The sooner that we can enact this, the more pharmacies that we can literally keep from closing their doors this next year. And with that, Madam Chair, I'll turn it over to the testifiers.
Thank you. First, I have Jessica Atrup-Eckert. I apologize if I mispronounced your last name.
I have two last names and neither of them are like normal, so I get that a lot.
Welcome to the committee, and please go ahead and state your name and begin your testimony.
Thank you. Good morning, Madam Chair and members. My name is Jessica Astrup-Eckert, and I'm a pharmacist and third-generation owner of Astrup Companies. I've seen a few of you up here before. I think I started testifying up here about 6 years ago, and we're still really pushing for major change in pharmacy reimbursement. Our family operates 12 community pharmacies, 4 long-term care pharmacies, and a specialty infusion pharmacy in Minnesota. We also have 1 pharmacy in Iowa. Our pharmacies are called Sterling, for those of you who are familiar. Sterling was founded by my grandfather in 1952. We grew our business to more than 20 locations, 20 community pharmacy locations, and have slowly downsized our footprint in order to remain viable. Many of our stores and others like ours are still at risk of closure. Recently, Minnesota has seen some of the highest levels of pharmacy closures in America. In 2024, another 32 pharmacies closed, including our pharmacy in Faribault. As of 2024, 17% of Minnesotans live in a zip code without a pharmacy. This stat doesn't even begin to capture the deserts that will exist when just a handful of other independents close. Currently, our pharmacies in the southeast corner of the state are the only pharmacies in Houston County, and many other independents are in the same situation, often serving medication needs for a vast geographical area. Pharmacy closures are not only devastating rural Minnesota patient access, but the current unsustainable pharmacy reimbursement model is creating urban deserts in parts of major cities like Minneapolis and St. Paul. We need your help now. I'd like to give you a few real human examples of the impacts of further closures and continued PBM challenges. We have a patient named Sharon who lives 12 miles from one of our stores and 17 miles from any other pharmacy. She's legally blind and on an injectable medication that requires her to draw a dose out of a vial. The medication would be lethal if given at the improper dose. For this reason, our pharmacist draws up the dose, delivers it to her home, and watches her give her dose every time, every week. It's people like Sharon and as many as 1.2 million other Medicaid beneficiaries in our state who suffer when independent pharmacies close. Without us, Sharon would require home nursing, which is not readily available in her rural area, or assisted living. Another example, our pharmacy in Faribault closed last year because of underwater reimbursement. We had a deep partnership with a local clinic for the underserved, Health Finders, for those of you who are aware. We developed a cost-effective formula and cash pricing strategy that made medications accessible for their vulnerable population, many of which are newcomers to our state. But our closure left patients without access. This clinic has used other pharmacies in town, but the care and dignity of their patients has not been maintained. Independent pharmacy fills a critical void by providing hands-on patient care and relationships, even in areas that are not technically pharmacy deserts. We know our communities and their unique needs, and we are responsive to those unique needs as they change. We often care for the most complex and most vulnerable patients in our communities. Every person needs access to a pharmacist and timely access to medications. If our locations need to serve a broader geography to ensure that all patients have access to quality care, we want to do that. However, we can't do that with today's reimbursement. Last week at our managers meeting, I was talking to our pharmacy manager in Fairmont, and he was expressing his frustration about filling EpiPens for one managed care Medicaid plan. Our cost on the product is $279.30, and our reimbursement is $181.34. The plan only allows brand EpiPen, which is not available from the manufacturer, or one specific generic. That generic is not available as a preferred product from our wholesaler, so we don't receive a rebate. We can't buy it elsewhere for this cost, yet it's a life-saving medication that our patient needs. I'm kind of combining two bills into one in the sake of time, so you'll hear a little bit about underwater reimbursement, but what we're really asking for is a short-term solution and then to start working towards something longer term. 60% of more of our managed MA claims are reimbursed at less than my cost to get the medication in the hands of the patient. It's simply not sustainable. I'm here today, like I said, seeking support for two bills. The short-term solution is 2152, Directed Pharmacy Reimbursement Model, designed to provide a lifeline. Additional funds, $4.50 per dispense, to buy us time to put a longer-term solution in place. The proposed additional payment clearly does not help with a dispense like my EpiPen example. However, we're hoping that a blended average will allow us to keep our doors open a little longer. Our runway is getting very short. The second bill that I'm here to support is up next on the agenda, I believe, 1574, which would authorize the Department of Human Services to change the medical assistance drug benefit to a single PBM model, more of a pharmacy benefit administrator model or a pass-through. We believe that a single PBM model using NADAC plus reimbursement, which has been proposed by Senator Mann and Representative Nadeau, is a longer-term solution for pharmacies to be able to sustainably serve our community's MA population, keep our pharmacies open, and even expand the geography that we can provide quality independent pharmacy services to for several years or generations to come. So that was a lot regarding two bills, but I appreciate you having me and welcome any questions.
Thank you very much. Next, I have Andrew Russell. Welcome to the committee, and please state your name for the record and begin.
Thank you, Madam Chair and members of the committee. My name is Andrew Russell. I am co-owner of Elko Newmarket Family Pharmacy, a small independent pharmacy located in Elko Newmarket, just south of the Twin Cities metro area. I'm here today representing Minnesota independent pharmacists in support of Senate File 2152. Independent pharmacies are a crucial access point for healthcare in our communities, often, as in my case, the only healthcare entity. We are the first point of contact for patients seeking advice on medications, managing chronic conditions, and navigating the complex healthcare system. We provide much more for our communities than just prescriptions. We live, bank, shop, dine, pay taxes, and vote there. We sponsor local sports teams and volunteer our time at many community events. Our patients are more than just patients to us. They are our friends and neighbors, and they are treated like family when they walk through our doors. Service like ours cannot be provided through the mail when we're closed. Patient access starts with an open pharmacy. Unfortunately, pharmacies throughout Minnesota have been closing at an alarming rate. Over the past 10 years, around 44% of all Minnesota pharmacies have closed their doors. 58% of these pharmacies have been independent non-chain pharmacies. Since 2023, a total of 40 Minnesota pharmacies have closed their doors, with 8 Minnesota cities losing their only pharmacy. Pharmacies are also closing everywhere, both rural and urban areas. MDH estimates that more than 1/3 of residents in Minneapolis, St. Paul, and the first ring suburbs are living in pharmacy deserts. In a 2024 study, Minnesota ranked 10th in the nation for having the largest proportion of residents living in a pharmacy desert. The pharmacy infrastructure in Minnesota has been crumbling for years, and Minnesota pharmacies are frankly at a breaking point. We're on the precipice of a pharmacy access disaster if action is not taken quickly. The pharmacy reimbursement model is broken. We just cannot keep kicking this can down the road. Senate File 2152 helps address what is widely regarded as the primary driver of pharmacy closures: unsustainable under-reimbursement by pharmacy benefit managers, or PBMs. In this case, the multiple PBMs contracted by managed care organizations to administer the medical assistance outpatient prescription drug program, which, as noted before, accounts for about roughly 85% of pharmacy enrollee coverage through MA. In 2024, the fee-for-service pharmacy dispensing fee, which is intended to cover the costs associated with filling a prescription, was raised to $11.55 based on the state cost of dispensing survey from 2021, which means this data is also pretty far behind. Regardless, this increase did not and does not apply to the prescriptions reimbursed by MCO contracted PBMs, again, about 85% of our enrollees. These massive PBMs continue to reimburse pharmacies dispensing fees less than $1, sometimes even $0, often leading to total reimbursements that are well below operational costs and even less than the cost of the drug product itself. This is simply not sustainable. There is a substantial need for community pharmacies throughout Minnesota, and no shortage of business either. In fact, we have been approached by several city governments over the last few years asking if we would be able to open a pharmacy similar to ours in their community, cities like Becker, and most recently the city of Lonsdale, who lost their only pharmacy in 2018. Unfortunately, after careful consideration, the answer each time has had to be no. As the way we are forced to do business virtually guarantees it will not be successful. Despite the overwhelming demand for our services in today's PBM-dominated reimbursement climate, the math just doesn't work. Senate File 2152 would establish an add-on directed pharmacy dispensing payment to qualifying rural, underserved, or independently owned pharmacies, providing a much-needed lifeline for pharmacies to preserve access and improve health outcomes for the state's most vulnerable patients. I would like to conclude by reiterating, patient access starts with an open pharmacy. Although this bill is not a long-term solution, it is a critical step towards keeping pharmacies afloat until more comprehensive PBM reforms can be implemented. I urge you to support and pass this bill. It is a vital lifeline for our independent pharmacies and the patients we serve. Thank you for your time, and I welcome any questions.
Thank you. And the last testifier I have listed is Hildy Heschen. Welcome to the committee, and please state your name for the record and begin.
Thank you, Madam Chair and committee, for having me today. Hello, my name is Hildy Heschen, and I'm a nurse and the creative director at St. Paul Corner Drug in the Matt Groveland neighborhood of St. Paul nearby, a pharmacy that I've worked at in some capacity since I was young enough to fit in a baby Bjorn strapped to my pharmacist's father's chest. Linda, David, Miriam, Kyle, Suzanne, Eric. These are all names of patients that responded within hours when we asked for their stories in our pharmacy's most recent news bulletin. Because they care about our survival, a few of them fill at least one of their medications at a local chain because we'd otherwise lose money filling it for them. Dave fills his brand name blood thinner via mail order for the same reason, but I help him do it for free because he can't do it on his own. Eric doesn't even fill his prescriptions with us yet. He's been coming to us for vaccinations since the COVID-19 pandemic and is anxiously awaiting being taken off our new patient wait list, which we implemented again last month for the second time in 3 years. Because in our industry, due to pharmacy benefit manager abuse, more business isn't better. More patients simply means more prescriptions filled below cost. And as you've heard from the testifiers before me, the math just does not work. All of these patients' emails and texts to me told the same story with different specifics. Patients need high-quality, local pharmacy care. I would bet that a good chunk of us here in this room take at least one prescription medication. I know I do. For some, it simply makes us feel better or prevents long-term consequences. But for patients like our patient Linda, who is a type 1 diabetic, having access to a local pharmacy is a matter of survival. She will die without her insulin. But we do so much more than fill patients' prescriptions. We triage walk-ins, we check their blood pressure, we educate them on chronic disease management, we vaccinate them and help our communities gain herd immunity. And most of this we do without scheduling an appointment or billing an office visit. Pharmacy is essential health care, and having access to it locally is both a necessity and in peril due to PBM abuse. And once a local pharmacy like us closes, we won't be back until PBM reform is achieved, and our healthcare system won't be the same without us. Who are you and your family going to call when we aren't there anymore? I implore you, listen to independent pharmacists like Andrew and Jess who went before me, and my father, John, who's speaking about the next bill. Hear and work to understand our story so that we can continue to provide excellent, life-altering health care to Minnesotan communities, and support this critical lifeline legislation and the bill you're going to hear about next, because we're currently losing pharmacies faster than we ever have before. Thank you, and I welcome any questions.
Thank you very much. Members, do you have questions or comments about the bill? Senator Abler.
I just put in a quarter, give the speech. It's like Groundhog Day, and for $4.50, where pharmacies are going to stay open, how sad is that? I mean, we should absolutely do this, but like, holy cow, what do we think they're supposed to do? You know, and I don't know who sets these rates, but I'm just...
PBMs, pharmacy benefit managers.
You know, yeah, thank you. But it's like, we just talked about a healthcare advisory workforce thing, and we've had healthcare task forces, and at the heart of all this, at least in every topic, is we need pharmacies to be out there. And, you know, PBMs have a benefit. Perhaps they're cheaper and somebody makes money off of it, and maybe they're a value. But there's something about having a person you can go talk to face. And I've given this speech 10 times, and apparently it didn't work very well, so I'll do it the 11th time. But something is wrong. I'm on the topic of conscience these days. Conscience and duty and service. The doctors out there took a Hippocratic oath. Maybe we should have a PBM oath that they should have duty and service and care about people. The pharmacists care about it. With all, I think the first testifier mentioned, when the PBM reform happens, like, they have a lot of money. They're not reforming anything. And they bought Washington, and it is just wrong. And while we watch our system implode all around us, and all done by remote control, I don't know how to stop it. I've said this over and over, and in a bipartisan way, we care about this. And Senator Mann, and to the pharmacy people out there and all the little providers everywhere, please keep caring. And Madam Chair, I don't know how we can offer relief. These bills come up over and over, and so now they're down to $4.50 we're going to be saved. I mean, well, multiple millions of dollars get extracted and shifted around in the dark of procedures behind the scenes. We don't even know what they are. And meanwhile, hardware store owners' insurance rates are going up doubling in what they were before all the reforms. And I don't, we better do this bill, Madam Chair. Thank you.
Other members, questions, comments? Senator Liskey.
Thank you, Madam Chair, and Senator Mann. This is definitely a discussion we've had, it feels like, for all 3 years that I've been here. It's concerning. I appreciate pointing out that Lonsdale is missing its pharmacy. We lost our clinic due to costs as well. We are now basically a healthcare desert other than myself. I'm the only, and the dentist, we are the only providers in the city of Lonsdale. It puts a lot of burden on those of us that are still there, and it puts a lot of burden on our patients who are now having to travel for other services that they normally didn't have to travel 20, 30, 40 minutes for before. You know, we have a population that's aging out there, and the number one concern when the clinic shut down was that now they have to drive to maintain their same providership. And the same thing was happening in 2018 when the pharmacy closed. Unfortunately, there's lots of reasons for that pharmacy to have closed, but I think a big one was the affordability side, right? Where's the hours worth it? You know, is it worth keeping open for the small amount of money that they might be making? And some days they're actually losing. And I don't know how this bill is going to fit. Obviously, we know there's a budget issue in front of us, and I don't know how we're going to make it. Hopefully, we can try and make it work. You know, the concern is how much will this bill actually help those pharmacies that are in dire straits survive? Will they make it with this bill? I think this is a Band-Aid, and I wish that the Band-Aid would stop the bleeding, but it won't. And I don't know when we're going to find an actual solution. You know, I hope that these other ideas maybe are the solution, but it doesn't mean that they are, and making them work is going to be a challenge. So, you know, I look forward to seeing how this goes. I really look forward to trying to get something to make something work to keep the pharmacies we do have open. And, you know, I want people to know that I am paying attention and I am trying to also work on solutions. You know, Senator Mann and I have conversations all the time. How do we get through this? And it's a much tougher question than just a simple, hey, this is going to fix it. So thanks for trying. We're going to keep trying, and, you know, I look forward to seeing where this goes. Thank you.
Any other member questions or comments? Senator Mann, any final comments?
Thank you, Madam Chair. Yeah, I mean, this is not the end-all, fix-all. This is very temporary. I think a bigger, better solution comes next bill. So this is just part of the conversation, and that's it. Thanks, Madam Chair.
Thank you for bringing this forward. It does try to address, you know, a need in the short term, and maybe not in a full way, as we can tell that it wouldn't be a complete solution, but we do have your other bill coming up. So this bill will be laid over. Senate File 2152 is laid over for possible inclusion. Senator Mann, you have Senate File 1574.
Thank you, Madam Chair. I do have an author's amendment.
Senator Mann has the A1 amendment. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The A1 amendment is adopted. Senator Mann.
Thank you, Madam Chair. So Senate File 1574 is the single PBM model legislation. So once upon a time, PBMs once served a function to lower cost for prescription medications. Unfortunately, PBMs have morphed into something else. If they were standalone companies, the three largest PBMs would each rank among the top 40 U.S. companies by revenue. The largest of these, which is Caremark, generates more revenue than Ford or Home Depot. How is it possible that a company that was hired to bring down the cost of prescription medication now generates more revenue than most companies in America, and the prices of prescription drugs continue to go up? So this is partially because the demands from PBMs for bigger rebates in order to place drugs on preferential tiers on drug formularies subsequently drive up the cost of drugs. And this allows the manufacturer to pocket their profit, while the larger rebates to PBMs who pocket their profits, and then in turn give rebates back to the plans who pocket their profits. And in order for everyone to pocket their profits along the line, patients have to pay more. So frustrated by the rising costs and seeking a simpler solution, states across the U.S. have looked at ways to remove PBMs from their state plans. A middle ground approach, first tested in Kentucky, has been shown to save states hundreds of millions of dollars. 3 states, Ohio, Louisiana, and Mississippi, followed suit in Kentucky's footsteps after the state implemented such a program in July of 2021. With that approach, Medicaid MCOs still get paid for providing pharmacy benefits, but must contract with a single PBM and use a preferred drug list selected by the state versus a complete MCO carve-out, which other states have also done and have also saved millions of dollars. The single PBM model essentially acts as a pharmacy benefits administrator that prohibits the PBM's use of nefarious money-making practices that extracts money from the system but does not provide any benefits, like spread pricing, clawbacks, below-cost pharmacy reimbursement, and made-up non-specific formulary fees. And unlike the current system, this system is very transparent. Louisiana went to a single PBM model in 2019, and they're saving about $50 million per year. Kentucky switched, and by 2023, the state had saved $283 million. Ohio switched to a single PBM model and saved $186 million in year 1 and $230 million in year 2. They had projected about $100 million saving each year. So with that, Madam Chair, we'll kick it over to the testifiers.
Thank you. I show John Hessian as the only testifier. Welcome to the committee, and please state your name for the record and begin.
Good morning, Madam Chair and committee. My name is John Hessian. I'm a pharmacist and current owner of St. Paul Corner Drug, which has been in the McAllister-Groveland neighborhood of St. Paul for 103 years now. I've been there a little over a third of that time, serving the community. I'm here today to speak on behalf of the other independent owners in the state that aren't able to be here because they're in the trenches doing the hard work for Senate File 1574 in support of. Minnesota Medicaid currently uses managed care model to provide coverage for approximately 85% of the beneficiaries. There are presently 8 different managed care organizations, each of which subcontracts with a for-profit PBM to pay pharmacies for prescriptions covered by Medicaid. There's a chart in your packet to kind of illustrate who they are and how much of the market that they have. For 7 of the 8, the PBM is owned by an out-of-state corporation. These for-profit PBMs each separately control their payment rates to pharmacies, which in most cases are non-negotiable, and exert their market power to pay pharmacies as little as possible. It is not uncommon for the total payment to pharmacies to be less than $1 for a prescription, including the drug package, the product itself, and most importantly, the services provided by the professional staff. The state of Minnesota regularly conducts cost of dispensing surveys, collecting data from pharmacies to determine how much it costs the pharmacy itself to operate and provide necessary healthcare infrastructure to Minnesota residents. The most recent survey endorsed by the state shows that it costs an average of $11.55 per prescription, separate from the cost of the drug itself, to break even and be able to continue operations. Thus, every time a PBM from the above list of providers pays a pharmacy or forces a pharmacy to accept payment less than $11.55, the pharmacy is operating below cost. Currently, as many as 50 to 70% of Medicaid prescriptions, depending on where the pharmacy is located and which plans they're dealing with, are paid at an operational loss. And just to kind of illustrate what that means, I brought this is a list of all the prescriptions that my pharmacy filled in 2024 below operational cost. So the worst is on the top. The last page is where we get the $11.55 finally and break even. So just to give you some context of where we are here, it took us this far to get the actual cost of the drug back. Then we had to go this deep into this before we had enough revenue in the prescription to buy a candy bar. All the way down to here to be able to purchase a cup of coffee at a typical coffee shop. 2/3 of my business. It took 5 full-time employees, 2 pharmacists, 3 technicians, 8 months to do this work for nothing. I'll leave that up there just for you to ponder while we continue. The math doesn't work. Pharmacies that experience an operational loss in 2/3 of the prescriptions they dispense cannot remain in business, and sadly, many have not. You know, there's also, this is in your packet, the 40 pharmacies that have closed since the beginning of 2023. The term pharmacy desert has unfortunately become commonplace, discussed frequently in both the media and academic research. And following pharmacy desert is also economic deserts. When pharmacies close in towns, especially in rural areas, the rest of the economic infrastructure of the city tends to fade away too. Because as people have to travel elsewhere to get their prescriptions, they start spending their money in other areas, and the local businesses on Main Street tend to close up as well. Pharmacists are problem solvers. It's all we do all day, and sometimes in the middle of the night when a patient calls with a pressing issue. There is a solution. A thoughtful bipartisan group of legislators has investigated a different model already used in multiple states for Minnesota Medicaid to pay pharmacies, a model which the state has direct control over each prescription and how it's paid, and using a payment algorithm already established by the Medicaid fee-for-service program in Minnesota. Unlike the for-profit PBMs, whose sole goal is to pay pharmacies as little as possible and to have no reason to care whether a pharmacy remains in operation or not, the state has a responsibility to its residents to care about pharmacy infrastructure and at least attempt to minimize the number of pharmacy deserts in Minnesota. The model proposed in Senate File 1574 would give state direct control over Medicaid payments to pharmacies and give the state much more power and flexibility to ensure that as few Minnesotans as possible, both in urban and rural areas, have difficulty accessing prescription medication because their local pharmacy was crushed out of existence by the powerful PBMs. The viability of community pharmacy in Minnesota has been rupturing for more than 10 years. It's time for some repair. Thank you.
Thank you, Mr. Hession. I don't show any other testifiers, Senator Mann. Members, do you have questions? Senator Liskey.
Thank you, Madam Chair. Senator Mann, I appreciate what we're trying to do. We talked about the reason why in the last bill of why I'm looking for answers. You know, last year we talked about PBMs a lot. The year before that we talked about PBMs a lot. I thought maybe the PBMs would get a hint that there's something wrong and that the abusive relationship that we're in is not functioning. I thought some of these small changes that we were making were going to make progress and have a real effect on keeping pharmacies open. And it's clear that that's not what's happening. The changes haven't been effective, apparently. And so with that, we have a new bill that generally is not what I would normally support, because we're creating a new government approach to solving the problem. We're not allowing the private markets to solve their own problems, but it sounds like the private markets have been ignoring the fact that there is a problem. And so with that, we now have a bipartisan bill that's going to change things pretty drastically. And I'm not saying I'm opposed, and I'm not saying I'm for it. I have some concerns, because now we're going to pick and choose who that PBM is going to be, and it's going to be one PBM instead of multiple. And normally I find that with more minds, more thoughts, you find solutions, but it doesn't sound like that's what's happening. So I guess we'll see how this plays out, and I'm hopeful that it will have the positive outcomes that we are projecting, and that it won't have negative impact on our patients and those that are now going to have to make a decision with this. And so I look forward to seeing the change, and hopefully it will solve the problem, and I hope it doesn't create new ones. So with that, thank you.
Senator Bolden.
Thank you, Madam Chair. Thank you, Senator Mann, for bringing this bill. We have been talking about this for a long time. The entire time I've been in the legislature, this has been a conversation, and clearly it was an issue before that. Senator Liskey, I appreciate your comments, and you mentioned that this bill would cause a drastic change in the sort of the ecosystem, and I think that's what's needed. I mean, Senator Mann, as you talked about the profits of these companies, that is egregious. It is, there's company after company who are getting a piece, making a profit, and what does that mean? It means patients aren't getting their medications. It means pharmacies are closing. It's having drastic, terrible effects on patients and our communities, and we do have a responsibility to change that and have that look different. I appreciate that you are looking at something that has been tried and successful in other states. We don't have to reinvent the wheel. There are things that have been done that we could and should look to, but to continue down this path of allowing PBMs just to continue to rake in profits on the backs of patients and pharmacies in our communities is not sustainable. And so I do hope we can move this forward, and I thank you for bringing it.
Senator Udke.
Thank you, Madam Chair. And once again, a conversation that, as it's been mentioned, we've had this many times. And basically, when we look at the list of the local pharmacies that have closed, like everywhere across the state, we all have them right in our backyard. And it is very concerning. And what is the solution? I wished we had the magic wand, but I don't believe this does it either. Not saying that we don't try things and we don't need to keep the conversations going. I see and hear the numbers that these states supposedly are reporting, and they apparently are. But is that actually getting to the pharmacy? That's what concerns me. And then we look at the fact that we're engaging this through the Department of Human Services. That's another concerning spot. Those of us that hear from our counties back home say we're still working on green screens because that's the only way the State Department of Human Services can communicate with us. We are so far behind, and now we're going to bring something like this that needs real-time connections, transmitting patient data. They need this, they need that, and making all those things work like it currently does. It currently works. It's just not financially working for our pharmacists, and that's a huge problem. But I'm just concerned that we're going to set this back rather than moving the needle forward. So that's my concern at this point. We all realize that we need something because the pharmacists are doing a tremendous job on absolutely no income, and that's just not acceptable. When we walk in through their door, we go to them because of their expertise and their knowledge and what they do for us, and then they don't get rewarded for it, and that's just wrong. So let's see where this takes us. But thank you, Madam Chair.
Thank you. Senator Abler.
Madam Chair, I just reply really quick.
Senator Mann.
Yeah, so a couple things. One is we did talk to Ohio and we talked to Kentucky. Ohio specifically said that their pharmacies stopped closing because they are getting reimbursed now at a fair rate. So it absolutely is trickling down to the pharmacies. So that's why this bill is so important, because that certainly is a piece of it. And then the other thing is we're not asking DHS or the government to be the PBM. There is still a private company doing that work. So it's not like we're saying we're going to open up this new government entity to do all this work. So that's also just something to think about.
Thank you. Senator Abler.
Well, thank you. Did you want to respond, Sir Rocky? You're good? Okay. Well, it's a good debate. hey, another debate, another discussion, another way to save pharmacies, another way to serve people. Just want to remind, everybody knows, we're sort of in charge of the commercial market, the self-insured. They do whatever they want. We can't touch them to do anything. Medicare is 1,500 miles away from our control. But we're in charge of 1.4 million enrollees or so in the programs that we serve. And it's our job. And Senator Mann and others who are engaged here, people in the room, they all care about this in different levels. But at the end of the day, the success of those programs is up to this table and tables like this and two bodies that vote on things and a governor who signs. And Senator Mann, thank you. It's not working. What we're doing now is not working. And I wish it was simply a policy discussion. This would be done a long time ago. And I'm not going to spend a lot of time talking about how things really are, but there's other rooms besides this room. There's rooms that are small with individuals in them and people that have influence. And so I believe everybody here isn't part of those rooms, and which is why we're still talking about it. I've never seen a more effective prop, sir, than that. And that's understating how cool it is. It's like my chiropractic practice is much the same. We're open, but barely. And it's about service. At the end of the day, it's about service. It's about this committee's commitment to service. And with all respect, and you know I support the health plans at least sometimes, we just don't want to do it. That's their letter. Like, hey, it could cause some interruption in patient communications. Like no health plan ever had a bad patient communication, and other letter. I mean, the health plans, we created you. In Minnesota, you exist as nonprofits to serve 1.4 million people and others along the way in the commercial market. That is your duty. We give you all kinds of benefits. And then to get in the way of trying to help these individuals, the clinicians that want to serve in pharmacies and the docs and the patients and nursing homes and everywhere that are benefiting and being served by Medicaid, Minnesota Care products, it's your job. And I think you need to remember it's your job. And we're losing it. We are in deficit everywhere. And we're spending more money than ever on healthcare in this state to have our people be sicker and have costs go up for no benefit and more middle people. And it's just wrong. And so, Senator Wiklund, thanks for getting on the bill. I'm glad this is a bipartisan bill with strong bipartisan authors. I encourage the governor to get out in front of this and to say, we have got to stop. I encourage the commissioners, Senator Kupek says, you want this done right? Send it to the ag. Okay, maybe we'll send it to them. And they'll really make it functional. No disrespect to DHS. So they try really hard. I can't imagine their job. And that's who should do it most likely. But it is time. And at some point, it has to be today that we do this. And we have to get out in front of the big money, the big influence, the big power who has undermined so much of our healthcare system. We used to be the pride of America with our healthcare system. And now there's not much to be proud of. And it's time to get back and pay attention to companies and states that have led the way on this in this way and begin to claw our way back to being a system that we're all so proud of. So I guess that makes me a yes, Madam Chair. Thank you.
Thank you. Senator Port.
Thank you, Madam Chair. Thank you, Senator Mann, for bringing this bill. You've talked a lot, we've heard a lot about how this can help pharmacies be able to stay in business, which is a critical part of this. But I think also thinking about what that cost looks like passed on to patients is a really important piece. And perhaps this is one step towards removing some of the incentive of insurance companies and PBMs to deny care, deny coverage of prescriptions. Perhaps this is the first step to, limiting that incentive and instead making, the state has an incentive to make sure that our people are getting the care that they need. And I think this could be a great first step. So thank you for bringing this bill.
Thank you. Any other member comments or questions? Seeing none, thank you, Mr. Hessian. I also appreciate your bringing forward, just helping us understand the magnitude of the problem. We have had discussions over numerous years about practices that to me seem like they should have been resolved because people would understand that this is not a sustainable practice that the PBM is requiring and that things would change, but they aren't. So I think we need to look at more different solutions, creative solutions, and I appreciate your bringing this bill forward, looking at what other states have actually implemented to help us find a way forward. And excuse me, I look forward to more discussion about it. At this point, we're going to lay the bill over, and we need to get a fiscal note, obviously, on it, and if there's any other work that needs to be done. But I really appreciate the time you've spent on it and that we were able to have this really good discussion today. So Senate File 1574, as amended, is laid over for possible inclusion. And next, Senator Mann, you have Senate File 2413.
Thank you, Madam Chair. I do have an author's amendment.
Senator Mann has the A1 amendment. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The A1 amendment is adopted. Senator Mann.
Thank you, Madam Chair. Senate File 2413 establishes a direct payment program to benefit the entire hospital community across the state of Minnesota. It does this by putting an assessment on Minnesota's hospitals in order to draw down additional federal Medicaid dollars. These additional dollars will be critical in stabilizing MA funding for Minnesota's hospitals. Minnesota hospitals never quite recovered from the pandemic. Services are closing all over the state: maternity wards, pediatric wards, mental health wards. And hospitals are doing this in order to keep their doors open. 40% of Minnesota hospitals and health systems had a negative operating margin last year. Directed payment programs are not new. They are a tried and tested way for states to leverage more federal money into underfunded Medicaid providers. By implementing a directed payment program as designed, Minnesota can capture an additional $1 billion in federal Medicaid funding to stabilize our healthcare system and preserve access to care. This bill will be just like 40 other states that are currently doing this. The way that the bill is structured, the assessment is only on the hospitals and not on any other healthcare provider. And the assessment will not raise prices on healthcare consumers or the health plans. We've also structured the bill in a way that the assessment and disbursements are done on a quarterly basis with timelines that ensure minimal lag time between the two, which will allow for hospitals to manage any cash flow challenges. And with that, Madam Chair, I'll turn it over to the testifiers.
Thank you. I have Rick Brewer. Welcome to the committee, and please state your name for the record and begin.
Madam Chair, committee members, I'm Rick Brewer, CEO of Community Memorial Hospital in Cloquet, an independent critical access hospital. Thank you for allowing me to speak here today. I've worked in healthcare for 35 years, with the last 25 of those years being at Community Memorial. I've witnessed a lot. I've seen the disruption of Y2K, the struggles of the recession of 08-09, and of course the extreme challenges of the COVID pandemic. Each of these events caused unique difficulties I hope not to experience again. This is difficult for me to talk about. I'm here today to tell you that operationally, I see problems and strains in healthcare that are truly unprecedented in my career. A major factor creating increased stress in hospitals is Medicaid payments falling farther and farther behind cost. Quite simply, these payment shortfalls threaten our ability to maintain independent, community-based care. Rural healthcare can be thought of as an ecosystem. Beyond often being one of the largest, if not the largest employer in a community or region, a hospital's not just a hospital. We often also operate a nursing home, a clinic, home health, hospice, EMS, and many other important community-facing programs. Stress on any part of that ecosystem stresses access across that entire system. There are truly ripple effects. Many hospitals in Minnesota are struggling. We each have stories we can share. In Cloquet, we've seen a significant deterioration of our financial position over the last 5 years. These losses are not sustainable. They have caused service line closures and suspensions, and they will continue to cause these until and unless our operating situation improves. Many of my rural colleagues are facing similar challenges. This is not crying wolf. This is not hyperbole. Hospitals are closing service lines. Some Minnesota hospitals are at very real risk of outright closure. One of the most challenging rural service lines is labor and delivery. I would argue that for rural hospitals, no service line loses more money per patient served than labor and delivery. And a large part of that has to do with who's paying the bill. For many rural hospitals in Minnesota, 15 to 20% of our patients are covered by Medicaid. But when it comes to labor and delivery, half of the moms and babies delivered or more may be covered by Medicaid. So Medicaid funding disproportionately affects access to rural labor and delivery services, where access is already coming under increased pressure. The shorter a mom has to travel for prenatal care and to deliver a baby, the better the outcomes are for mom and baby. A directed payment program can offer stability needed to preserve access to care for underserved communities, especially for moms, babies, and children across the entire state of Minnesota. Thank you for your time and consideration of this critical legislation.
Thank you very much. And next I have Trevor Sawalish. If you could state your name for the record and begin.
Thank you, Madam Chair, and thank you, members of the committee. My name is Trevor Sawalish. I am the Chief Executive Officer for North Memorial Health. For more than 70 years, North has been more than a healthcare provider. We're a vital part of Minnesota communities. North Memorial has always said yes to everyone who calls upon us for care, no matter who they are or where they come from or their ability to pay. We stand firm in our commitment to provide the best care every patient, every time. Being here for our patients and their families is a promise, and a promise that we hold to our very core. As a quick overview of our system, we have 2 hospitals. One is our Level 1 Trauma Center in Robbinsdale, Minnesota, and the other is the Maple Grove Hospital, which has been a leader in baby deliveries year over year with over 5,500 births last year. Between the 2 hospitals, we also provide 30,000 admissions and 115,000 emergency department visits in a year. We also have 25 clinics, including 45 specialties, and are the largest ground and air ambulance, our EMS system in the state, with over 100,000 transports per year, with our air service providing coverage to the entire region, not just Minnesota. North is a very important part of an integrated healthcare infrastructure for the state. Moreover, I represent 6,600 team members who have dedicated their careers to serving the people of Minnesota. We need help now. North is here with all the other providers of the state because Medicaid and Medicare reimbursement are not keeping pace with our costs. Our mission and the care that we provide are at risk. North Memorial serves a disproportionate share of patients covered by Medicare and Medicaid, with 74% of our patients at Robbinsdale Hospital covered by a government program or are uninsured. Medicare and Medicaid underpayments drive more than $180 million in losses on an annual basis. Without help, without this legislation, without adjustment, we are going to face service closures, facility closures, and even more dramatic and difficult decisions in the future. These are services that our communities need. These are services that are a critical part of the infrastructure for health in the state of Minnesota. There is no ambiguity, there is no crying wolf, as Rick said, about the changes and difficult decisions that we're going to face. As this does affect the whole of the state infrastructure, all healthcare providers support this plan together. Directed payment programs are already a proven solution for over 40 states, providing critical financial stability without burdening state budgets. The bill would authorize participation in directed payment program, assess hospitals to provide funding necessary to draw down the federal dollars, and the turnaround time for those funds is intended to be tight so that hospitals can afford to do this out of cash flows. While the federal government may change the rules regarding directed payment programs, these programs are so embedded in how states across the country are paying for medical care, and in both red and blue states. We are hopeful that the directed payment programs will be sustained for that reason. But we have to get our legislation passed here in Minnesota first to get ourselves in the queue for consideration for this important program. We are tirelessly doing our part as the hospitals of the state and look for your support. Thank you, Senator Mann, Chair Wiklund, and the committee members for your consideration of this important legislation.
Thank you very much. Next, I'd like to call up Chelsea Olson. Welcome to the committee, and please state your name for the record and begin.
Good morning. My name is Chelsea Olson with the Minnesota Council of Health Plans. The Minnesota Council of Health Plans and our nonprofit members share the concerns over low MA reimbursement levels and the impact that this has on providers and patient access. Low MA rates also impact commercial rates, which are well above the cost of care to offset the loss from MA rates. We appreciate that the funding mechanism used in this bill does not create a new tax that will add new costs on commercial premium payers. Instead, this program uses existing funds to leverage federal money to increase MA rates for hospitals, which has the potential to help alleviate the existing cost shift on commercial rates. We appreciate the intent of Senate File 2413 and are supportive of the concept. As the organizations tasked with administering the flow of $1 billion each year, we do have a few changes we would like to see to lessen the potential administrative burdens. This includes the MCO payment timelines in the bill, and we would request that these align with the industry standard of 30 days. Note that 30 days is the longest, the maximum of time that MCOs would have to make payments. Our members pledge to turn around these payments as quickly as practical, but 5 days is just too short. We also have concerns with the financial penalties imposed on plans for the delays, which may be outside of our control. Line 6.30 in the amended language already includes a prohibition against MCOs unnecessarily delaying a directed payment to a hospital. Lastly, we request clarifying language be added to the bill to ensure the program ends if federal funding ends. We appreciate our discussions with the proponents and the authors who have been receptive to our requested changes, and we look forward to continue to work with them on this concept. Thank you.
Thank you. Members, do you have questions or comments about the bill? Senator Abler.
Thank you, Madam Chair, and it's an appealing idea. My good friend Representative Nadeau is a champion of this in the House, and he's encouraging me to become a fan. I am concerned about the federal ability to pay this stuff, but could staff just kind of walk through how the mechanism works? There's an assessment, and then you get some money, and then, so I'm just unclear, maybe is there really $1.8 billion? Maybe we could just walk through the math, just at high level would be nice.
Mr. Hidalgo, could you walk through the mechanism? I'm not sure if you can address the dollar amounts, but, or.
Thank you, Madam Chair. Senator Abler, I can do a brief overview, but it looks like maybe there's someone who would like to step in to assist with further details. The assessment will be raised, go to DHS, which would then go to the federal government CMS, which would then provide the FMAP matching funds for that. DHS would determine the directed payment amount based on claims information that's gathered. Those would then go to the managed care organizations in the total aggregate funds would go to the managed care organizations through the state's capitated payment rates, which would be increased. Then the MCOs would pass that additional payment through the directed payment to the providers themselves.
Madam Chair.
Senator Abler.
So maybe it's just, and that's helpful, but I'm just curious about like the gross numbers. I remember on the bill you had Senator Wiklund, there was $800 million and then there was $1 billion. And does the $800 million stay in Minnesota? Do we lose that and then that's 200? I'm just trying to get that, just the most big picture of the big picture on the gross numbers is all I'm after.
Senator Mann or Mr. Pollock?
Thank you, Senator Abler, for the question. I think you're asking about the dollar amount. So it is quarterly, so it wouldn't be all at once. But the structure of the program is that the hospitals would have an upfront assessment, an estimate of their assessment due over the subsequent year based on prior year claims. So the analysis is all done ahead of time. And then the mechanics of it is like what Senate Council described. On a quarterly basis, you would have the cash flow move from the hospitals, approximately 200 if it's an $800 million program, going into DHS. DHS reviews it, passes the money to the health plans. That gets paid as a separate payment term along with the capitation payments to hospitals. And so they would be getting the money back within 30 days of that quarterly amount. And all of this would be transparent and in a separate segregated fund. So unlike the current revenues that the hospitals already pay into the state, we'd be able to see the money moving in and coming back out.
Senator Abler?
Well, I'm just, okay, and I appreciate that, but just so, I mean, somebody said there was $800 million and the feds give us $1 billion, and we keep the 8, so it's $1.8 billion. Is that correct? Or is the money that we get, I mean, just the grosses of gross numbers over any amount of time you want, just so I just want the big picture, and it would be interesting that we get $1.8 billion out of 800, so that didn't ring right to me, so that's all I'm asking.
Mr. Pollock?
Madam Chair, Senator Abler, the top line numbers are correct. That's based on the modeling that an independent consultant did that basically reflects the fact that the federal match is higher than 50-50 with different blended populations. Blended rate is higher than a 50-50 federal match under the current law, current structure. So your $800 million paid in draws down a Medicaid payment back that has more than 50% federal dollars.
Madam Chair.
Senator Abler?
So the $800 million stays in Minnesota, or does that go to the feds?
Mr. Pollock. Madam Chair, Senator Abler, the $800 million stays in Minnesota. It's the state's cost of paying a new Medicaid capitated rate. So it's the non-federal share being paid in Minnesota.
All right, so I think I'm just about done, Madam Chair. So
Senator
we
Abler.
spend $800 million, the feds give us $1 billion, we get to spend it kind of sort of how we want, but based upon what I just want to make sure that's the thing, so. All right, it's helpful, and just to remind people that they're kind of broke out there. And so some people are a little worried about $880 billion, and $881 billion might be even a bigger number. So, but I appreciate this explanation, and I guess they're still passing out money, so at least Minnesota should get its share while they still have some checks they can write. Thank you.
Senator Utke.
Thank you, Madam Chair. No, I was just going to add to that conversation, but they got through it, so I don't have anything additional.
Okay, thanks. Anyone else have questions or comments? I don't see any other questions or comments. Senator Mann, I appreciate your work on this and the ability to think about this in a creative way to try and find a way to address hospital needs. It is concerning when we hear about the difficulties, especially in greater Minnesota, for a hospital to maintain their services, and we know that those services are extremely important to Minnesotans. So I think it is really important that we're looking for all the options that are available to help address those needs. This bill, members, needs to move to taxes. And so, do you have any final comments, Senator Mann? So Senator Mann's motion would be that Senate File 2413 as amended be recommended to pass and be referred to the Committee on Taxes. Members, all those in favor, please signify by saying aye. Aye. Any opposed? The motion does prevail, and Senate File 2413 as amended is passed and referred to the Committee on Taxes. Thank you, Senator Mann, and that brings us to the end of our agenda. and we are adjourned.